Hello, good morning, good afternoon, everybody. Welcome to our latest in our series of ARC Talks webinars. We're delighted to have joining us today Dr. Sharmila Dorbala, who is a renowned expert in cardiac imaging and in particular in amyloidosis. And in this webinar, we're really going to hear some, I think, invaluable insights into how advanced imaging techniques can really be used to enhance diagnosis for these complex conditions. Just by way of background, the Amyloidosis Research Consortium, ARC, is a nonprofit foundation. We thank you all for your support, and our vision is to make a significant impact on the curability of amyloidosis. I'm Isabel Lusada. I'm the CEO and founder of the organization. And we have 4 areas that we focus: improving the speed and accuracy of diagnosis. So it's a real relevance how imaging is used. The 2 center pillars are around the science and improving the research and science by understanding the disease more clearly and accelerating drug development and regulatory approval. And lastly, the program that ARC Talks fits in is enhancing care and quality of life of patients. We have a robust portfolio of patient programs to really help support and inform the community so that individuals can learn to advocate better and understand their disease better to get the best treatments. I'd like to thank our sponsors for today. And without any further ado, I'm delighted to hand over to Dr. Dorbala.
Thank you so much, Isabel. All right, please confirm that you're seeing my screen.
Yes.
Perfect. All right, thank you so much, Isabel, and thanks to ARC for inviting me. And I'm truly honored to be here to be presenting about visualizing amyloidosis, the role of imaging. So I'm a cardiologist, and my area of expertise is cardiovascular imaging with a focus on imaging of amyloidosis. I've been working in this space since 2007, and as most of you are aware, a number of significant developments have happened over the last 10 years or so. So what will I do over the next 45 minutes? I'll give you a little overview about amyloidosis, talk about how we diagnose amyloidosis, how we can image amyloidosis using the different imaging techniques: echocardiography, cardiac magnetic resonance imaging, radionuclide imaging. Show you 3 examples of cases where we used imaging in caring for someone affected with amyloidosis. And then lastly, I want to end with a little bit of information about how imaging could potentially be used to to identify change in therapy. So to start with, what is amyloidosis? So this is a group of systemic disorders that are caused by proteins that are misfolded. A variety of proteins: transthyretin, apolipoprotein A1, lysozyme, immunoglobulin light chain, as well as a number of other proteins, can misfold and form these long non-branching fibrils. These fibrils can deposit in the various organs: the heart, the kidneys, the spleen, various other organs, causing organ dysfunction. So when we talk about cardiac amyloidosis in particular, I think of it as 3 broad categories. The first one is immunoglobulin light chain, or AL amyloidosis. This comes from a problem with the plasma cells in the bone marrow. So this is a bone marrow problem, and this affects men and women equally and is typically treated by chemotherapy. This disease has a slightly more rapid progress or disease course compared to the other forms. The more common form that we see in clinical practice is transthyretin, or ATTR cardiac amyloidosis. This is misfolding of transthyretin protein that's normally produced by the liver and a few other organs. This protein can misfold either because of aging, and that is called wild-type transthyretin amyloidosis, or it can misfold because of a variant in the TTR gene, and then you have transthyretin variant form of amyloidosis. So either of these can affect the heart, and then we call this transthyretin amyloidosis. We now have number of different treatments. Stabilizing drugs to stabilize the wild type transthyretin amyloid, and silencing drugs to treat the variant type of amyloid. Then the less common forms of amyloid in clinical practice are all of these. They can affect different organs, including the heart as well. And the key point to remember is what we are treating currently is the precursor protein, both AL and transthyretin. However, we're not treating the fibril, which is deposited in the organs. In terms of imaging, what we're imaging is the fibril. And therefore, you need to keep that disconnect in mind. And new treatments are now coming up for treating the fibril, and imaging will play an important role in these conditions. So how do we diagnose amyloidosis? So independent of the precursor protein, whatever the protein may be, once the fibril is formed and goes to various organs, people may experience difficulty breathing, irregular heart rhythm, can have slow heart rhythm or irregular heart rhythm. They can have musculoskeletal problems, carpal tunnel syndrome symptoms, low back pain from lumbar spinal stenosis, what is called a ruptured biceps tendon. You can have other orthopedic manifestations as well. The variant form of TTR more commonly manifests with painful neuropathy in the feet and hands. Then some people can also develop muscle weakness, difficulty walking, and falls. Autonomic neuropathy, which is low blood pressure when you stand, and intolerance to blood pressure medications, changes in your gastrointestinal tract, diarrhea, constipation, weight loss, and erectile dysfunction can all be seen with the various forms of amyloidosis. So the point I'm trying to make here is the symptoms of amyloidosis may suggest the disease, but the symptoms are highly varied. Therefore, typically patients go to different doctors. The treatments are distinct based on the precursor protein. And keep in mind that the presence of symptoms, these are all non-specific. It doesn't automatically mean that this is amyloid. So imaging is very important to find the presence of amyloid and to find the type of amyloid. So typically, if the doctor suspects amyloid, what would they do? Particularly in the heart, they would order an ECG, an echocardiogram. So ECG is an electrocardiogram, sorry. So the ECG is a very simple and painless test for those of you who had it. It shows us the electrical activity in the heart. It tells us your heart rate. It tells us the rhythm of the heart, whether it's regular or irregular, and it tells us whether the complexes are small or big. So for example, this is an ECG from an individual with transthyretin form of amyloidosis, and we see what is called conduction system abnormalities. So by itself, this ECG is not very specific. But when we look at the previous ECG of this same individual from 7 years prior, we recognize that this ECG changed substantially. It was very narrow complex QRS, what we call, and here it's wide complex with a lot of heart blocks. So basically, ECG is one of the first tests which would raise the suspicion. It's not sensitive or specific, but certain features on the ECG can raise the suspicion of disease. Most often, doctors would order an ultrasound exam of the heart called an echocardiogram or a magnetic resonance imaging study of the heart. And I'll share more details about this, but these can further corroborate the suspicion of amyloidosis. And if the thought process at that point is this is light chain form of amyloidosis, then these steps could be taken. The doctor could send off tests from your blood and urine to send off blood tests for free light chain assay, serum and urine immunofixation electrophoresis. So what this tells you is it tells us something about the bone marrow. Is the bone marrow showing a plasma cell dyscrasia and producing these abnormal light chains that could misfold? That's one part. The next step would be to see whether these abnormal light chains are forming amyloid fibrils in any of the organs. And this is typically a biopsy diagnosis. So either the bone marrow, fat pad, kidney, heart, involved organ biopsy. But the third part is, does this individual have amyloid in the heart? How do we know that? So in someone who has biopsy proof of amyloid, and it confirms that this is light chain amyloid, you can look at abnormal cardiac biomarkers, blood tests, or abnormal imaging of the heart. And all of this together could suggest that this is immunoglobulin light chain or AL amyloidosis affecting the heart. For a disease where these fibrils are depositing the organs, one would think biopsy could be the way to go. And yes, it is confirmatory in most cases, but it's invasive. So think of a heart biopsy. We put catheters through the vein in the neck, going into your right heart and taking small bits of heart muscle tissue. We're just snipping small pieces of the heart muscle and sending it off to the pathology lab. So this is an invasive day procedure. The pathologist could stain it with Congo red or one of the other amyloid stains. And all this pink here is amyloid. And in between, these are all heart muscle cells. So basically in the heart and in other organs, the amyloid deposits between the cells, between the normal cells in that organ, all right? So far we have said, yes, there's amyloid in the heart biopsy, but we don't know what type of amyloid. And again, treatment, as I said, depends on the type of amyloid. So this amyloid is then sent off for typing. And the reference standard for typing is something called mass spectrometry. We send off our samples to Mayo Clinic, and they would run analysis of this amyloid tissue, and they would come up with an answer. What is the type of amyloid? Is it light chain, transthyretin? Is it wild type transthyretin variant or one of the other forms of amyloid? So this is how you would go with biopsy. But what are the challenges with biopsy? It's a procedure. You need to schedule the procedure. Typically, it's not used for early diagnosis because by the time a doctor is thinking of biopsying the heart muscle, the individual should have had some degree of symptoms and suspicion of amyloid. So usually it's by the time you think of heart biopsy, it's a little late in diagnosis. You cannot quantify amyloid in the heart. Remember, I showed you the picture. You take 4 or 5 snippets on one part of the heart, and you're assuming that what you see there represents the amyloid in the entire heart. Of course, this is not a good test to look at treatment response. So here's a cross-section of the heart muscle from a patient with an explanted heart who went to cardiac transplant. All this yellow is heart muscle cells, and the green is amyloid. You can see amyloid around the blood vessels even. So depending on where you blindly biopsy with your needle, you may see no amyloid, which is very unlikely in this disease, or you may see small amounts of amyloid, moderate amounts of amyloid, or significant amount of amyloid. So biopsy, although confirmatory, has some limitations in quantifying the amount of amyloid, and this is where imaging has an advantage. Imaging provides whole heart amyloid burden estimation. So it tells us not only amyloid in the heart, but with the newer techniques, we can measure amyloid in multiple organs within the body. So what about diagnosing the transthyretin form of amyloid? So here, of course, if the heart biopsy shows transthyretin amyloid, you're done. But in most patients, we don't send for biopsy with this disease. We would look at imaging. If there's typical features of amyloid, then we exclude a plasma cell dyscrasia by looking at blood tests, free light chain assay, and immunofixation electrophoresis, and urine immunofixation electrophoresis. And once this is excluded, once we say it's not AL amyloid, say this looks like amyloid, but it's not light chain amyloid, then we would go ahead and proceed with a radioactive test. This test is called PYP-DPD or HDP. This is a radionuclide testing where we use a small amount of radioactive material to image amyloid, directly the amyloid. So if you see amyloid in the heart, you know that in a patient who doesn't have AL, it's most likely transthyretin amyloid. So this is the summary of what we discussed so far. Transthyretin amyloid can be diagnosed with imaging, and we do not always need a heart biopsy. light chain cardiac amyloid requires some form of biopsy proof, either from the heart or from the other organs. And you need to know that the heart is involved based on imaging. What about the other forms of amyloid? These forms, we do need biopsy. Maybe the advanced imaging with PET radio tracers, as we discussed, may be a potential avenue for the other forms of amyloid. So how can we image amyloid? So I already introduced this briefly with you. So echocardiography is ultrasound exam of the heart. And as you can see, this is a painless test. Basically, this is an ultrasound machine. These are the probes. Here we use sound waves. We transmit sound waves from the probe, and we collect the reflected sound waves from the heart or from the kidney or whatever organ you're imaging. All right. So this test will show us the size and shape of the heart. It'll tell us how well the heart is pumping. And using a technique called Doppler echocardiography, we can also look at how well the heart is relaxing and filling with blood. Both pumping and relaxation of the heart and filling of the heart with blood, both are important in amyloidosis. What about MRI? Most of you must have heard of this. Here's a test where we image water content in the heart. So this is the MRI machine. We can take moving pictures of the heart. And basically, this test is well tolerated by most people. If you don't tolerate, if you have claustrophobia, we can give you some medicine for it. It's a fairly simple test. There's some noises you hear inside the machine. Again, we can give you earplugs for that. But other than that, it provides almost all the information that's produced by echocardiogram, but in a much higher resolution. In addition, you can see that MRI can characterize the tissue. What does it mean? It not only tells you the shape, function of the heart and the pumping function of the heart, the size of the chambers, but it tells you areas of the heart where there's increased water content or fat or fibrosis or scar content or amyloid content. And it tells you what is muscle. So basically, using this test, we have additional advantages of being able to characterize the tissue and in the case in point to characterize amyloid. Remember, MRI cannot be performed in people who have certain pacemakers or medical devices or metal in the body. So that is something to keep in mind. What about radionuclide imaging? So this is a scanner. This is a test where we use special scanners called SPECT or PET scanners. And we use a small and safe amount of radioactive substance called a radio tracer, and that creates pictures of the heart. So the radio tracers are specific to the physiology you would like to study. So they're tracers that can image blood flow to the heart muscle, tracers that can image amyloid in the heart muscle. So here's an example of an amyloid tracer, and what you're seeing in color here is amyloid in the heart. The grayscale image is a CT scan of the chest, cross-sectional CT scan. Here's your lung tissue in black, this is your heart, and this is amyloid. The radio tracer that we use to image amyloid with SPECT techniques goes to the bone as well, so this is all normal. This is physiological bone uptake, but it's not supposed to go to the heart muscle. So when it goes there, that's abnormal and pathological. So coming back to what we are imaging with amyloid. So here's a schematic of a normal heart. The two lower chambers called the ventricles, two upper chambers called the atria, and these are the valves. The left ventricle is the thickest chamber. The right ventricle is the next thickest chamber. And there's a lot of heart muscle cells here. What happens when amyloid deposits in the heart? It gets in between the heart muscle cells. Therefore, it increases the thickness of the wall. The wall becomes very thick. The cavity becomes small. You can see that the right ventricle, the bottom chamber of the heart, both the right and left, both of them become very thick. All right. So what you're seeing in this condition, amyloidosis, is the effects of amyloid in the heart or other organs. So what does it do in the heart? It makes the heart stiff. So the normal heart should be contracting and relaxing with each heartbeat. But once you add amyloid into the heart muscle cells, it makes it a little harder for the heart to relax. And the initial phase of the disease, it contracts normally, but it has challenges in relaxing or filling with blood. And that is what accounts for the symptoms of difficulty breathing. That is one of the commonest symptoms experienced by people with cardiac amyloid. So here's an ultrasound exam. Here's your left ventricle, right ventricle, atria. This is a normal individual. And here's a patient who has amyloid. So this is images from a person with amyloid. And you can see that the echocardiogram shows bright and sparkly myocardium in the wall thickness. Look at how thick this is, the left heart and the right heart compared to a normal heart. Okay, so this is one of the classic features of infiltration, any substance getting into the heart, and in this case, amyloid, and that's what you see. The bottom two chambers called the atria also tend to dilate with amyloidosis. The valves can also thicken with amyloidosis. What else can you see? You can see stiffness, increased stiffness. So normal heart stiffness measured by this technique called Doppler, which we spoke about earlier. You can see that there's nice diastolic filling movement of the mitral annular plane, but in a stiff heart, it's very little movement, okay? Very little movement. And this is classically what you see when the heart is stiff from amyloid. What about heart pumping function? Look at how the heart is pumping here, very vigorous, normal. And on the right side is the heart of an individual affected with amyloid, and you can see the ventricles not pumping as vigorously. Look at the right ventricle, it's thick, but again, not pumping as vigorously. The two upper chambers called the atria, big in size. The most important feature is this part called the mitral annulus, where the valve is moving very vigorously in a normal heart. Amyloid decreases that mobility, okay? So not only do you see reduced pumping function in this fashion, in how the heart is visually overtly contracting, but you also see reduced longitudinal contraction of these speckles. These speckles are not moving up and down as they are here. So that can be measured with something called global longitudinal strain. And global longitudinal strain, normal, would look something like this, with a lot of longitudinal movement. And in amyloid, you see that the apical segments of the heart move well, but the mid and basal segments do not move well. And global longitudinal strain is reduced in a characteristic fashion in amyloid. What about MRI? It shows the structure and function of the heart, just as with echocardiography. And here you can see thick walls, right? Small pericardial effusion and pleural effusions. Contrast this with a normal MRI. Right, so this is characteristic of amyloidosis. Plus, you can see what is called late gadolinium enhancement. So we use a contrast agent called gadolinium. Once we give it and we use a special sequence, we can produce images of the heart where the normal heart muscle looks black. Okay, here you can see normal heart muscle is completely black. But when there's amyloid in the heart muscle, we can never make it black. The MRI signal cannot be nulled. So this is called late gadolinium enhancement. And you can see that this is almost the opposite of what you see here. The myocardium is all grayish, whitish, not black, and the blood pool is dark. Again, this is a characteristic feature of infiltration of the heart muscle with amyloid. The other tissue characterization is called extracellular volume. So what MRI can provide is measure the space between the heart muscle cells. So in a heart where there's no amyloid, you can see that the shown in color, extracellular space is normal here. Extracellular volume is normal in this color code. In a heart where there's amyloid infiltration, this extracellular volume is expanded. This is increased, okay? you can also see the wall thickness is increased. This diffuse increase in extracellular volume is characteristic of amyloidosis, and it can be quantified. So the big advantage of this is you can tell how much ECV there is in the entire heart. The only downside to this is extracellular volume can be expanded with a number of different heart conditions, amyloid being one of them. So it could be increased from fibrosis in the heart for any reason. If there's scarring in the heart muscle from a heart attack, typically it's regional. It's one part of the heart, not the whole heart. But other forms of heart failure, you can have interstitial, what we call fibrosis, and the extracellular volume can be expanded. So this is a great technique. It can give us insights into amyloid. It can quantify the amount of amyloid. In people who have amyloid, we believe it likely represents amyloid burden. But in the early stages of disease, where the extracellular volume is not significantly expanded, we are not able to say this is amyloid versus non-amyloid forms of heart disease. So again, we still need further information. So look at the radio tracers, coming back to the nuclear method again. The same heart section that you saw earlier, blue-green is amyloid. Here on the right side, we took this slide and soaked it with an amyloid imaging radio tracer. And you can see the radio tracer, when we wash the slide, it's only sticking to the areas where there's amyloid. Okay, so what is radionuclide imaging with amyloid tracer showing? It's showing us amyloid. This is specific for amyloid. It cannot be seen in any other pathophysiologies or any other forms of heart disease. So if the question is this amyloid, these radio tracers can be extremely helpful. This is not new. Radio tracers called pyrophosphate, DPD, or HMDP have been around for many years now. Look at this, since the early 90s, 80s. We knew from publications from Dr. Falk and others at that point that if you see uptake of this radio tracer in the heart muscle, this indicates presence of amyloid in the heart. All right. Of course, technology has evolved and it has now emerged into what is called SPECT CT. So the grayscale is CT, the color image is the P by P. And I don't know if I can ask questions on this or take a poll, but I'll give you the answer. There's nothing in the heart. This is just background activity. It's a negative study. We know this is a good test because we are able to image the bone. So very important. You see bone uptake, so the tracer is working, but you see no uptake in the heart. So this is no evidence of transthyretin amyloid. The reason I say this is this test is not a good test to exclude AL amyloid or the other forms of amyloid. So just because the P-by-P scan is negative, it doesn't mean other forms of amyloid don't exist. So remember that. So this is a good test. If it's negative, most likely there's no evidence of transthyretin amyloidosis in the heart. Contrast that with a positive image on the right side. You see again uptake in the bone. This is your spinal column, vertebral uptake. You see rib uptake. But then what's different in this case is you see uptake in the heart muscle, all this color, the bottom image. That's the left ventricle. And here's your right ventricle. So there is diffuse uptake in the left and right ventricles. This is a positive case on the top compared to a negative case on the left and right. All right. So this test gives a signal of amyloid in the heart. Again, a positive test doesn't tell us whether it's transthyretin or light chain form of amyloid. It just tells us that amyloid, it's a much stronger signal in transthyretin form of disease than in the light chain form of disease. Again, very important because we need to exclude AL amyloidosis by blood and urine tests in all patients undergoing this P-by-P scan. Why? Because this could be AL and the treatment may be completely different. So remember that again, a negative test does not exclude AL amyloid. A positive test can be AL or ATTR. So go ahead and exclude AL by further testing. This test was studied in a multi-center, nearly 1,500 patient study, nearly 400 with heart biopsy from the National Amyloid Center and 7 other centers, including multiple centers, including our own study center here at the Brigham. In this test, what they showed was if there is myocardial uptake of tracer, which is equal to rib or greater than rib uptake, and your AL plasma cell evaluation is negative, your serum free light chain assay, serum and urine immunofixation electrophoresis are negative, the test is nearly 100% specific to diagnose transthyretin form of amyloidosis. Okay, so based on this seminal study, we are now able to treat patients with transthyretin amyloidosis diagnosed by this test without need for endomyocardial biopsy. All right, to summarize, what are we imaging? With echo, you're looking at structure and function of the heart. You're looking at longitudinal contraction of the heart, but it cannot really tell you whether these abnormalities that you're seeing on echo are from amyloid or from non-amyloid pathology. MRI, we can look at structure and function better than even echo, provides tissue characteristics. It can tell us, is it fat, scar tissue, amyloid, expanded extracellular volume, especially if it's diffuse and significantly expanded, it can quantify the amount of amyloid. It is better than echo to show or distinguish amyloid from non-amyloid pathologies, but it still is not definitive for amyloid. It's not definitive for amyloid. So radio tracers, SPECT and PET, show amyloid. This is the major difference. This is how you image amyloid, and MRI and echo is how you image the effects of amyloid on the structure and function of the heart. Here you can look at PYP-DPD, and they directly show amyloid, and there's some novel PET tracers that we can also talk about. So a few case examples. How do we use imaging in clinical care? So a 73-year-old man presents with new onset difficulty breathing. So when we talk to him, he has progressive osteoarthritis of the knee. He was planning to get a right total knee replacement. On questioning, he also reported that he had carpal tunnel syndrome, bilaterally requiring surgery about 10 years before. We measured blood tests called cardiac biomarkers, and this test called NT-proBNP tells us about stretch on the heart muscle from heart failure. That was abnormal. And troponin T tells us that there is heart muscle injury. That's frequently also abnormal in amyloidosis, so this is abnormal here. So based on the clinical manifestations and the laboratory tests, the suspicion was very high that this difficulty breathing could be related to amyloid in the heart. So what would you do next? I won't show all the tests, but you would normally do an ECG, probably an ultrasound or echocardiogram. Here's the echocardiogram. You can see the left ventricle is very thick. It's bright and sparkly. It's contracting well. So it's kind of the overall pumping function looks good here. But when we look at longitudinal contraction, that's severely reduced. And here's your relaxation properties, which are severely reduced. So the clinical suspicion was high. The echocardiogram further suggests that this is most likely amyloidosis. So given his age, they felt it was transthyretin form of amyloid, therefore referred for a pyrophosphate or PYP SPECT CT scan. Of course, by now, all of you probably recognize this. This is abnormal. You see uptake in the heart. You're not supposed to see anything for a negative study. So this is now abnormal. So does he have transthyretin amyloid is a question. Again, remember, we cannot tell based on this test whether it's light chain, transthyretin, or other forms of amyloid. It tells us that this is amyloid. So you do need to exclude light chain amyloidosis. So he underwent plasma cell evaluation that was negative. Therefore, the conclusion was this is transthyretin form of amyloid. Then we sent off a genetic test, and he did not have any TTR variants. Final diagnosis thus is wild-type ATTR cardiac amyloidosis. How do you treat this? You treat this with tafamidis, a TTR stabilizing agent. So I hope I gave you some insight into how the evaluation progresses from clinical suspicion based on clinical manifestations, then do some imaging like echocardiography, and confirm the diagnosis, especially with transthyretin amyloid using imaging. This individual does not require biopsy. Next patient, here's an 82-year-old woman who came to us with difficulty breathing. And this was going on for 1 year. And she did have some swelling of her feet. And her ECG or electrocardiogram showed an irregular heart rhythm, also called atrial fibrillation. So what was done in this patient is that it was unclear whether this was amyloid or not. And typically the transthyretin form of disease is much more often seen in male patients than in female patients. And it's possible that that could be underdiagnosis in women, we don't know. But when you're not clear whether this is amyloid, whether it's transthyretin or light chain, or whether it's even amyloid at all, then the first test could be an MRI. So this patient was sent for an MRI. So MRI shows thick walls, big atria, small pericardial effusion, fluid around the heart, pleural effusion, fluid around the lungs, all this white. And on the right side is the so-called late gadolinium enhancement. After giving gadolinium contrast, you see this is a short axis, a cross-section of the heart like that. The right ventricle is here. This round is the left ventricle. It has a lot of late gadolinium enhancement. So once you have late gadolinium enhancement, these features are highly suggestive or consistent with amyloid in this case. So what would you do next? You, of course, exclude AL amyloid. So kappa lambda free light chains were studied, very abnormal, and abnormal kappa lambda ratio. So what does it tell you? It tells you there is a bone marrow problem. There is abnormal production of these lambda light chains that could potentially form fibrils and deposit in the organs. And it's possible that's what you're seeing in the heart. But you still need proof of amyloid. So in this case, a fat pad biopsy was performed. It confirmed amyloidosis, and typing confirmed that this was AL amyloid. Cardiac biomarkers, again, abnormal, saying there's some cardiomyocyte injury. There's myocyte stretch, heart muscle cells are stretched out, so very, very abnormal. So final diagnosis in this case was systemic light chain amyloidosis with cardiac involvement. Patient received chemotherapy with Cybordi and daratumumab regimen. Again, whether you do echo or MRI as a first imaging test really depends on the doctor's suspicion of amyloid versus non-amyloid causes of heart failure and many other factors. But once you're leaning towards transthyretin, you would go with PYP, radionuclide image. If you're leaning towards light chain form of amyloid, you're studying biopsy. So this woman participated in a research study with us, and we used a PET amyloid tracer called fluorobutapir. And you can see that this amyloid tracer showed amyloid in the left and right ventricle. Remember, we could not do PYP because PYP is unreliable for imaging light chain form of amyloid, and it can be negative. In fact, in her case, that was negative. But fluorobutapir and amyloid PET tracer shows that it is strongly positive. Moreover, it shows uptake in the spleen. All right, in AL amyloid, you can see amyloid deposition in the spleen, and here's splenic uptake. What you see in the liver here is physiological radiotracer excretion. So this is not amyloid, this is normal excretion of the radiotracer. So I'll show you one more case and move on to the last part of my talk. This was a 74-year-old man who comes with loss of consciousness during exercise. ECG was normal, heart catheterization was normal, no blockages in the coronary arteries. The only abnormality was his kidney function. So basically, they went ahead and performed a heart biopsy on this patient, found amyloid, sent off to Mayo Clinic, and mass spectrometry confirmed ApoA4 amyloid. So here's the echocardiogram on this individual. You can see bright, sparkly myocardium, right? And here's your longitudinal contraction, abnormal. Relaxation is abnormal, not as bad as the previous cases. So this individual also agreed to participate in a research study with us, and we used this new tracer called ebusamitide. You can see beautiful imaging of amyloid in both the heart, right and left ventricles. How is this helpful in clinical practice? This is currently investigational and hopefully will soon go into a phase 3 clinical trial. This is going to advance the field a lot because we are not waiting until advanced disease manifestations. What I mean by that is you would not send someone for heart biopsy to exclude amyloidosis to find a negative result because it's an invasive test. Whereas at the earliest clinical suspicion, you could consider an imaging test. And if that's negative, you could be reassured that it's unlikely to be amyloid and you pursue other investigations for the symptoms. Or it could be positive, and as seen in this case, then you could perform selective biopsy only in people who have an abnormal PET test suggesting amyloid in the heart. Of course, this could also have huge implications for assessing treatment response. So if you now think of novel treatments that are coming on board, we could perform an image before treatment is initiated, and we could theoretically perform an image after treatment is completed to see how the treatment has affected the amyloid fibrils in the heart. Again, remember, this is where I want to come back to the point that current therapies are focusing on the proteins. Imaging is focused on amyloid or the effects of amyloid in the heart structure and function. So remember that with new drugs that can target the amyloid fibrils, these imaging tracers will actually gain importance not only to diagnose this disease, but to even look at treatment changes probably. So this part summary, transthyretin amyloid may not need a heart biopsy as you saw in the first case. AL amyloid requires biopsy proof, as you saw in the second illustration where we did a fat pad biopsy and then we did MRI to show heart was affected. And in the third person, we found another form of amyloid and amyloid in the various organs using these advanced PET tracers. So what's in the near future? The last 2 minutes. The near future is really advancing this field further, trying to understand in people who have systemic biopsy-proven amyloid, where an advanced test like MRI is normal, could they be early amyloid in the heart? And here's an example from our ongoing research work, where we found that even when the heart is normal looking on MRI, the PET tracers may pick up early amyloid. So this is an early phenotype before there's overt changes in heart structure or heart function. Or you could see something like this, where the PET scan is negative and says, this is a true negative. The patient has systemic AL amyloid, but in this particular individual, the heart is spared. Or it could be this, where the individual has systemic AL amyloid, but the heart is affected and not seen by MRI, but seen by molecular imaging techniques. This is hopefully the future. And the other future we hope for is to use amyloid-directed tracers to image different types of amyloid. Remember, I told you that the PYP currently is targeting predominantly the transthyretin form, maybe the AL amyloid, but it's very unreliable for AL amyloid. With the amyloid PET tracers, we can look at transthyretin, variant, wild type variant, AL amyloid, right? And this is a different radio tracer showing the same thing. Splenic amyloid, lung amyloid, and here liver amyloid with ebusamitide. So again, we hope that advances in molecular imaging will help us characterize disease burden, not just in the heart, but in the whole organ, and give us a better sense of what's the overall amyloid burden in the overall heart. So can we use imaging to track treatment changes? Just one example of an individual's echocardiogram. You can see an image from 2021. Global longitudinal strain was -9. This was very abnormal. And this individual was treated with Tara-Cybo-D, and you can see 2 years later, the longitudinal function has improved. Okay, more negative is better. So -12.5 is significantly improved from -9.3. So here, all we've done is treated the bone marrow. We have not treated the amyloid fibril, but the heart function still has improved. With transthyretin, what we see is not as much improvement, but you see more stabilization of the disease. So here's global longitudinal strain. In this study, what we showed was that people who received tafamidis, the global longitudinal strain doesn't change very much. It remains about the baseline. But in people who were not treated, this is before tafamidis was available, the heart was progressively worsening. So you could see worsening of global longitudinal strain. So this is something that we are seeing in transthyretin form of disease, where treatments with stabilizing agents are stabilizing the disease and preventing rapid progression. The National Amyloid Center in UK showed that in people who have AL amyloid, if after chemotherapy, the global longitudinal strain improves, these patients have better survival compared to those patients where the global longitudinal strain does not improve, okay? So this is survival on the vertical axis, time in months in the horizontal axis. People who have an improvement in global longitudinal strain have better survival. They also looked at cardiac MRI and showed that people who have regression of amyloid, which is a very small number, or stable amyloid, those people have a better outcome compared to people where there is progression of amyloid. Again, AL amyloid, people receiving chemotherapy, if you see continued accumulation of amyloid on AL chemotherapy, those patients have worse outcomes compared to those where it's stable or regression. The most exciting thing in the field now is really fibril-directed therapies, because we now seem to have a reasonable therapy for the proteins. So here's one example from a publication with an antibody that's targeting transthyretin amyloid fibrils in the heart. Here's your bone avid tracer scan, cardiac uptake. After 4 months of antibody therapy, you see a significant decrease in the myocardial uptake of this tracer. At the bottom is a patient who received placebo, which is sugar pill, not the treatment. You can see there's no change in 4 months in the heart uptake, but once the antibody was administered, you see improvement. Again, this is how we hope imaging can help us with new drug development, help us assess treatment response and advance. So to conclude, misfolded proteins form amyloid deposits in the heart and cause amyloidosis and organ dysfunction. Cardiac ultrasound or echocardiography and magnetic resonance imaging can increase the suspicion of amyloidosis in people with symptoms that suggest amyloidosis. Radionuclide imaging can confirm the diagnosis of transthyretin amyloidosis in most affected individuals. If light chain amyloidosis can be excluded and biopsy is not needed for this particular diagnosis. Currently, we have no FDA-approved agents to image light chain amyloid in terms of radio tracers. Research studies that I shared with you show really promising results. Early diagnosis may be possible, and a phase 3 clinical trial is being planned. One is ongoing and another is being planned for one of these agents. So the future looks really bright for these agents. Thank you very much for your attention, and I'm happy to answer any questions. Isabel, you may
unmute. Thank you so much. That was really wonderful and amazing to hear the different role of imaging modalities in both assessing and in diagnosing amyloidosis. And the nuances of that were very interesting to hear. We do have quite a lot of questions, and so I'll read some out. And one of the things that was a few questions were on First of all, what are the different classes, the NYHA classes? What do they mean? And how early can you use imaging to diagnose amyloidosis?
Yeah, excellent question, Isabel. Again, very practical question. So the NYHA class has been developed really as a measure of severity of heart failure symptoms. So it goes from a person being able to do everything they're doing normally, or the person with no limitations, or a person having some limitations but able to do most of the things. Or the next class would be where you have more limitations. And class 4 would be where you're short of breath at rest. You're limited even at rest, and you have symptoms of heart failure even at rest. So NYHA class has been a simple tool that has been extremely helpful in understanding severity of heart failure symptoms and in understanding disease status and outcomes and things like that. So that's a very, very interesting question. Now, how early can you diagnose this disease? So we have some studies showing that, MRI is more sensitive than echo. So what I mean is your echo may be normal, but your MRI can show early changes in extracellular volume. And let's talk about maybe patients who have a TTR variant. So someone in the family is diagnosed with variant TTR. They already have heart involvement. Now family members are tested. The question becomes, okay, is the heart already affected in this person who's TTR variant positive? Bone avid tracer scintigraphy with P by P. There was a study by Dr. Ed Miller and Dr. Ruberg and others from BU, which showed that P by P imaging can detect early amyloid in some of these patients, even when the echo and MRI look negative. And I do believe that the PET tracers will even be better than that. So really the question becomes, how early? We don't have an answer, but we can detect earlier and earlier disease with molecular imaging tracers, with MRI, better than echo for sure.
Excellent, great answer. There's a couple of questions about if you see increasing abnormally low longitudinal strain numbers, what does that mean the heart is failing to do properly?
Yeah, good question. So we believe that the longitudinal contraction is limited in amyloidosis because of amyloid deposition. So now the question becomes, all right, this amyloid deposition, the longitudinal contraction is abnormal, but you're now on treatment. Let's say transthyretin TTR stabilizer, or the light chain form of disease where you've treated the bone marrow. If the longitudinal contraction continues to deteriorate, the question then becomes, why is that happening? And it could be that there is substantial amount of amyloid in the heart already, in that now the heart and heart failure and the dysfunction is progressing independent of amyloid. So there may be fibrosis, there may be other insults to the heart, which continue to worsen over time, which is the reason why I think we are now looking at a two-pronged approach of treating the precursor protein and also treating the fibril itself. So this is a completely uncharted territory at this point, because we didn't have treatments for this condition until recently. So now the question becomes, what is causing disease progression for people who are on what is considered effective therapies? And we believe the TTR stabilizers are highly effective at stabilizing TTR. Maybe the silencers are a little more effective than stabilizers, but so far we are yet to see whether the silencers are better than stabilizers for the heart. We don't know that yet.
Excellent. We do have a few questions that are about Jon Wall's imaging at the University of Tennessee, which is also a company called Attralus is working on this, and maybe you could touch on that.
Yeah, that's a good question. So some of the images I showed you, particularly the ApoA4 images, are using Jon Wall's compound. It's labeled with a radioisotope called 124I iodine. It's an iodine labeled radio tracer. This has a relatively long half-life, so it's made in, it can be made anywhere and it can be shipped to an institution that's far away. So we get our doses from a site in Tennessee, which shipped. This tracer, from what we have seen, we've imaged so far about 50 patients. And what we have seen is in non-amyloid healthy controls, it's completely negative. We see nothing in the heart muscle. It's a clean negative. In documented amyloid, persons who have documented amyloid, because this was an initial pilot study, we found that everyone who had documented amyloid, we saw uptake with this radio tracer. So it seems to be working very well in the controls who don't have amyloid and people who have amyloid. So Attralus is a company that's now taking this compound into a phase 3 clinical trial. So what that means is they will be hopefully soon, if they get approval, studying this compound in people with suspected amyloidosis, not just healthy controls or documented amyloid, but suspected amyloidosis. And that could open up a whole avenue of early diagnosis based on this.
Well, thank you. There was a couple of questions around imaging the role of tafamidis and saying, you know, if you image everybody who is old, would they show amyloid potentially in the heart? And is it always meaningful? So if you do have, say, PYP that shows some level of amyloid involvement, should you always be going to take a treatment like tafamidis?
Yeah, that's an excellent question. So I think I'm reading multiple points there. One is most people who have PYP positivity where AL is excluded, we currently believe are likely to be transthyretin amyloid and would be treated with TTR stabilizing drugs. So that would be the current practice. There are some people, for unclear reasons, the PYP may be negative, but they still may have transthyretin form of disease. And this has been particularly reported for patients with variant TTR, certain variant forms, where the bone avid tracer scan can be negative. So one thing I would say is, again, come back to the sensitivity. So the test detects 70% sensitivity. So if the test is negative, but all other imaging modalities are suggesting it's amyloid, those people may still need a heart biopsy for confirmation of diagnosis. So the PYP may be negative, but if the heart biopsy shows transthyretin amyloid, those people would likely benefit from going on tafamidis therapy because they have transthyretin amyloid in the heart. So I think that's what I would say. And at this point, we are not aware of, just extending one more point, is we don't know what it means to repeat the PYP scan on tafamidis. That is an active, ongoing area of study. Whether we need to look at changes in the image on tafamidis is not known yet. Currently, it's not clinical practice to repeat the scan, but it is clinical practice to follow the heart structure and function, repeat echocardiograms to look at how the heart function is stabilized, progressing, or improving with therapy.
Excellent. That's helpful. And there were a couple of questions about how often should any imaging scanning be repeated. So I think you touched on that. And I think we have time for one last question. And this one is, can these imaging techniques identify amyloid deposition in peripheral nerves?
Yeah, that's an excellent question, and it's an active area of research. I have seen one example where Jon Wall's compound was able to image peripheral nerve uptake, but we have not seen it. Kidney amyloid is, again, one area we are not able to definitively image with the molecular tracers so far. We can see some signals, but we are not so confident. Now, there's MRI techniques that are being studied to look at amyloid in the nerves. Again, investigational, but hopefully there will be some news on the MRI side as well soon for this. And it's a very relevant question for the variant type of transthyretin.
Mhm.
Yeah.
Excellent. Well, thank you so much. It was really enlightening. I think it's shows not just the how far we've come in the different techniques we use now, but I think also touching on the future and how much is evolving. And certainly patients, it's so helpful to know and really understand what a full picture looks like, whether it's amyloid or not. So much to still be done, and congratulations for all that you're doing to advance research. And thank you so much for taking the time to join us today for this wonderful talk.
Thank you, Isabel. Really, it's been an honor, and really thanks to the 200 or 300 participants who joined this to learn about imaging in amyloid. The field is progressing very rapidly, so we are very hopeful for the future. Thank you.
Thank you. Bye-bye.
Bye.